So this morning was about the lower GI tract, and this afternoon we're going to move into the upper GI tract, particularly focusing on functional upper GI tract disorders. So let's start with a typical case that we see in our practice. A 20-year-old female medical student presents with a 6-month history of intermittent upper GI symptoms. She describes epigastric discomfort, worst after meals, associated nausea. She has reduced the size of her meals and has lost some weight. She's also taking opioids for back pain. She has a relevant past history of anxiety, a 1-year history of anorexia in her late teens, and she's a medical student. She has Googled internet, and she's concerned that her diagnosis might be gastroparesis. Abdominal examination is normal. So the first approach, according to guidelines, when we have patients with dyspepsia, is to test for Helicobacter pylori and treat if positive. A meta-analysis of randomized controlled trials show a reduction in dyspepsia symptoms after H. pylori eradication with a number to treat around 12. And guidelines recommend that we consider upper GI endoscopy with biopsies for H. pylori in patients age 45 in Asia and 55 in Western world to rule out neoplasia. And endoscopy is also recommended in patients who present with alarm features. If H. pylori eradication has not worked for our patient, or patient is H. pylori negative, a trial of PPI therapy for 4 to 8 weeks is appropriate, and a concurrent meta-analysis confirmed that PPAs is superior to placebo, again with a number to treat of around 11. But provided that we have established that strategy with our patient and symptoms are present, what happens next? Well, she fulfills, that's absolutely true, she fulfills the criteria for both functional dyspepsia and for gastroparesis. And functional dyspepsia, less known by the general public than irritable bowel syndrome, is actually the most prevalent functional upper GI condition. And is defined by the ROM4 criteria as more than one of the following: postprandial fullness, early satiety, epigastric pain, or epigastric burning. Symptoms should happen at least 3 times per week and for the last 3 months without any structural disease. An important aspect is that gastric emptying can be abnormal in a small proportion, in a third of patients with functional dyspepsia. And at the same time, we have gastroparesis and gastric symptoms that are secondary to delay gastric emptying, and also very similar presentation: postprandial fullness, early satiety, epigastric pain, although some authors suggest that vomiting is more common. And as I say, there's delayed gastric emptying in the absence of outlet mechanical obstruction. Of course, the key here is that the prevalence of functional dyspepsia is very high in the general population, it's 12%, whilst idiopathic gastroparesis, as our patient doesn't have any other factor for gastroparesis, is very low. So logic dictates that our patient has functional dyspepsia rather than gastroparesis. But let's continue. So what are the predisposing factors for functional dyspepsia and gastroparesis? For dyspepsia, we have a Helicobacter pylori infection. It's more common in connective tissue disorders, congenital connective tissue disorders like Ehlers-Danlos. It's being increased recognition that there's an association with duodenal inflammation infiltrated with eosinophils, but there are drugs that can cause dyspepsia, can occur in patients after a gastroenteritis, post-infective functional dyspepsia. And regarding gastroparesis, the main cause is recognized to be diabetic mellitus, also following surgery, particularly for funduplication, and also patients with connective tissue disorders like sclerodermia or neurological disorders like Parkinson. But a big proportion of patients with marked delayed gastric emptying don't have a cause for the symptoms, and this is the idiopathic gastroparesis. The pathophysiology behind functional dyspepsia and gastroparesis is quite similar. They share some common pathways. In terms of dyspepsia, there is evidence that patients, a proportion of patients have visceral hypersensitivity. There is altered fundic accommodation during the postprandial period, and there is, as mentioned before, antral hypomotility in a proportion of patients and an infiltrate with eosinophils and mast cells. And regarding gastroparesis, as mentioned, the characteristic is that the patient have to have delayed gastric emptying, so antral hypomotility is common. There is pylorospasm, lack of relaxation of the pylorus due to degeneration of nitric oxide neurons, and there's been data confirming a change in the macrophage population, decreasing anti-inflammatory macrophage, increasing pro-inflammatory macrophages that through paracrine mechanisms have an effect on interstitial cells of Cajal, which have been demonstrated to be reduced in patients with gastroparesis, particularly diabetic gastroparesis. And the majority of the studies on the pathophysiology of these conditions have been done on functional dyspepsia, and there is a third of patients with delayed gastric emptying. There's also a proportion of patients that have fast gastric emptying. Accommodation, the ability of the stomach to relax after meals, is impaired. The stomach is more rigid, and that creates an increase in intragastric pressure after meals and causes symptoms, and there's increased visceral sensitivity to both mechanical distension and lipid infusions. And this, as I mentioned before, there is a recognition of increased infiltrate with eosinophils and mast cells. These eosinophils are important because stress not only facilitates release of corticotropin releasing factor by the hypothalamus, but also by eosinophils. CRF activates mast cells, and those release mediators that contribute to increasing intestinal permeability, and that it can contribute as well to increase traffic of antigens from food and from gut microbiota into the lamina propria and contribute to visceral hypersensitivity. And as with IBS, functional dyspepsia is considered a disorder of the brain-gut axis. Anxiety is more common in patients with functional dyspepsia. Longitudinal studies actually demonstrate that patients with anxiety and low mood have increased risk of developing over time symptoms of dyspepsia. More than 60% of patients suffering domestic violence have symptoms of functional dyspepsia. And anxiety in patients in general with functional gastrointestinal disorders are associated with reduced response to typical gastrointestinal medication. And I think the reason why I wanted to present this case as an example of the paradox between is this patient suffering from functional dyspepsia versus gastroparesis is that in general the approach with patients with functional dyspepsia is a more holistic approach, taking into account the role of factors, central factors like anxiety, depression, on gastric sensorimotor function and how symptoms of gastric sensorimotor dysfunction influence central mechanisms and influence anxiety and depression. Whilst when we diagnose patients with gastroparesis, we tend to have a more unilateral approach, which is simply focusing on improving gastric emptying. And I think that can be unhelpful and lead to increased iatrogenic harm in some of our patients. So the question then is, should we perform a gastric emptying study? If we don't do a gastric emptying study, then we won't diagnose gastroparesis, isn't it? And I participated in the European guidelines for both functional dyspepsia and gastroparesis, and I found that we got to a slightly confusing, we provided a slightly confusing message, because European guidelines for functional dyspepsia do not recommend that we perform gastric emptying study in the vast majority of patients. On the other hand, in order to diagnose gastroparesis, European guidelines indicated that we had to perform a gastric emptying study and have a confirmed diagnosis of gastric emptying. So it's quite paradoxical and very confusing. My view is that we should be performing a gastric emptying study in patients where we think that the gastric emptying is going to modify the management of our patients. Is that going to happen? And also, if we perform the gastric emptying, should be done in appropriate conditions. We need to be sure that there is no medication influencing the results, opioids, anticholinergic, that patients don't have factors like very low weight that is going to influence the gastric emptying. And are we doing the test because we have exhausted the conservative management and we are considering escalating therapy? So those are the questions that we need to think. And it's important to recognize, to remember the outcome of this very interesting paper that was published a couple of years ago. This was a study done by the Parkman Group in America, and they found that 15% of patients who had a diagnosis of gastroparesis, when the gastric emptying study was repeated 2 years later, they actually had normal gastric emptying. So they were reclassified as functional dyspepsia, and this was irrespective of the severity of the gastric gastric symptoms. Vice versa, 15% of patients who had a diagnosis of functional dyspepsia, when they had the gastric emptying study repeated 2 years later, were reclassified as gastroparesis. So as mentioned before, we should perform gastric emptying study if we are thinking of escalating therapy. Because in reality, patients with functional dyspepsia and with gastroparesis, if symptoms are mild or moderate, are going to be treated exactly the same, with dietetic, pharmacological, and probably psychological interventions if needed. And we will only consider endoscopic or surgical options, the latest, very rarely, in the case of very severe forms of gastroparesis. So the dietetic interventions are based on the principle that gastric emptying is is fastest when we consume liquids or when we consume blended or soft food, and gastric emptying is slower depending on the concentration of fat of our meals. And therefore, patients with gastroparesis should consume soft, low fiber, low fat fiber. And in order to reduce the discomfort, rather than having large size meals, we recommend small, frequent meals. And there's one study suggesting that a small particle diet reduces symptoms in diabetic gastroparesis. There's only one study using low FODMAP diet in functional dyspepsia, and there seemed to be an improvement in clinical symptoms. And interestingly, more than in the case of IBS, we're seeing an increase in the prevalence of disordered eating and avoiding restricting eating disorders in patients with functional dyspepsia because engaging in unhelpful dietetic behaviors. So this study was published around this concept, the fact that there's increased risk of avoiding restricting behaviors in patients with gastroparesis, and we also see the same in functional dyspepsia. A patient experiences discomfort when he's eating, reduces the meals, skips meals, and ends up with what we call an avoiding restricting eating disorder. They don't eat not because there's a body dysmorphia, because they don't want to gain weight, but because eating causes pain. But similarly, there's evidence that a high proportion of patients with classical eating disorders, for example, anorexia, have very high prevalence of functional dyspepsia. And which pharmacological interventions should we use in patients with dyspepsia and with gastroparesis? Let's start with prokinetics. Once we have tried PPIs or H. pylori eradication, and those approaches haven't worked. So regarding gastroparesis, there is no meta-analysis, and it's interestingly not endorsed by the European Society of Neurogastroenterology guidelines, but recommended by the American Society of Gastroenterology. For functional dyspepsia, it's superior to placebo with a number to treat of 7. The only consideration is that there were a number of trials included that included cisapride, and which is not available at the present time. And we have a number of drugs that we can use. We have drugs, we have prokinetic effect and antiemetic effect. For example, metoclopramide, which is a dopamine antagonist at a dose of 10 milligrams 3 times per day. We should avoid prolonged use because there is risk of tardive dyskinesia and extrapyramidal symptoms, and it can be associated with QTc prolongation. Domperidone is an antagonist of dopamine receptors, doesn't cross the brain barrier, so there is no risk of extrapyramidal symptoms, and its use is limited by QTc prolongation. And then we have drugs that have a purely prokinetic effect. Prucalopride is one of them. As you know, it's a prokinetic that we use for chronic constipation, but has an effect in gastric emptying. And erythromycin, in liquid form, used up to 4 times per day, is also very helpful, but after 4 weeks, there is tachyphylaxis. And personally, what I do is I alternate sometimes prucalopride with erythromycin, and it's a good option for some patients. Neuromodulatory medications should be used as well, or considering gastroparesis and functional dyspepsia. But in the case of gastroparesis, there's only one placebo-controlled randomized trial with no triptyline, which showed that there was no evidence, there was no clinical improvement, and there are no studies with SSRIs or SNRIs in gastroparesis. There is anecdotal evidence that mirtazapine can be quite helpful in both gastroparesis and functional dyspepsia. And the reason being because mirtazapine improves nausea, improves appetite, helps patients to sleep better at night. And when we have patients with severe symptoms and low weight, I personally and other colleagues find mirtazapine very helpful. Functional dyspepsia, there is no meta-analysis demonstrated there were no benefit for SSRI or SNRI. And contrary to gastroparesis, it seems that drugs like amitriptyline or imipramine could be helpful because they, particularly in patients who present with functional dyspepsia, epigastric pain subtype. Psychological interventions are helpful, particularly there is evidence for patients with functional dyspepsia. There is 9 randomized controlled trials with different interventions, particularly cognitive behavioral therapy, but there are no randomized trials for patients with gastroparesis. And what about endoscopic interventions? As I mentioned before, we should be very careful about considering endoscopic interventions in patients with dyspeptic symptoms, and we should offer those interventions in patients that have evidence, that have failed pharmacological interventions, have evidence of delayed gastric emptying, and they have severe symptoms. And those interventions are based on targeting the pylorus, based on the fact that a proportion of patients have pylospasm, and that facilitating relaxation of the pylorus will help gastric emptying. There are different options: Botox, pyloric dilatation, and the G-point. There are several open-label studies showing initially that injecting Botox, 100 units in the pylorus, could be helpful, but subsequent randomized clinical trials failed to demonstrate a difference between botulinum toxin injection and placebo in gastroparesis. There's been another subsequent study in 2017 which reported 75% improvement in patients who had normal gastric myoelectrical activity. It's in general not recommended in the majority of guidelines. We now have a new kid on the block, that's G-point. What G-point involves is injecting the gastric mucosa with a lifting agent, performing mucosal resection and advancing a cap-fitted scope towards the pylorus, and then performing resection of the circular muscle fibers. The figure on the right-hand side of the slide shows a pool analysis of 10 studies. Only 2 of them were prospective, and there was an 80% improvement in clinical symptoms with no clear relation between, and the study could not identify on the basis of the etiology of the gastroparesis or the severity of symptoms or the characteristics of the gastric emptying severity, which patients were more likely to benefit. Another study recently published involving 5 centers and 75 patients found a reduction, 50% reduction in the GCSI, which is a marker of severity of gastric symptoms. And again, this was irrespective of the etiology, diabetic, post-surgical, or idiopathic, but it seemed that the symptoms improved more in those patients who have a more severe GCSI score. Finally, there's the option of gastric stimulator, which is rarely used these days in Europe, still used in America. And gastric electrical stimulation is not a pacemaker. It's not pacemaking the stomach. It's not promoting gastric contractions, and does not improve gastric emptying. The mechanism of gastric stimulation is stimulating vagal afferents and working on nausea center in the brain, in the central nervous system. There's been 3 prospective clinical trials. Only on one of them there was a clinical difference between the on and off phase of the clinical trials. Basically, patients were fitted with a gastric stimulator, and what the authors compared was the improvement in symptoms with the stimulator activated on versus the stimulator not being activated. And in the other 2 clinical trials, there was no difference between the on and off phase, but interestingly, there was significant difference with the pre-implant symptoms, suggesting that either there was a placebo effect or there was a carry-on effect due to the stimulation by the device.
2 minutes, doctor. Thank you.
Yes, sometimes. So, summary, functional dyspepsia is more common in the general population than idiopathic gastroparesis, and the vast majority of our patients will have functional dyspepsia rather than idiopathic gastroparesis. And taking into account that the approach from a dietetic and pharmacological and psychological therapy point of view is the same, we should highlight this to our patients rather than engage in complex, potentially iatrogenic therapies. And in patients with severe symptoms not responding to conservative management, we can then consider gastric emptying if we are therefore considering escalating therapies, but not in every patient presenting to our clinic. So as gastric emptying should only be considered in patients with very severe symptoms because we are thinking of escalating therapy, not to every patient that comes. Thank you.